And we have saved the most beautiful for last, Dr. Shapiro. And I said that Dr. Herrick can stick a needle anywhere. I think this gal can as well. We've worked together for many years, and she's kind of the first doctor, like outside of my scope, that really got it and understood what the benefit of the cells, how they could affect the stuff that she was treating. And it was so refreshing to meet her all those years ago. And I'm so happy that she is here today. I really appreciate you coming, Roberta. She came all the way from New York, and I think she got in at 3 a.m. last night because of weather there and weather here. So I really appreciate being here, and please give her a warm round of applause.
Thank you. Dr. Reardon has left me 3 minutes, so I'm going to speak New York speed, I'm going to take my time. If you want to cut me off, you can cut me off. But my topic, he didn't even know this, and he's so courageous for giving me this opportunity to just say what I'm going to say, because I have actually never broached this subject publicly before. I've talked about it privately, extensively for the last few years, and it's become so prevalent with what I hear every day that I just started coining it the Wild West of stem cells in the United States. And I'm specifically talking about application in the United States. The reason I'm even here talking is because I have immense respect for Dr. Reardon and for what he does, and it's absolutely true. When we first met, it was the first person that I actually talked to and talked about my theories about inflammatory diseases and autoimmune diseases and better ways to start treating them, that he got it. He got it clinically. And he is the research scientist. He's like, I feel like we were almost separated at birth, because he's the research scientist correlate and I'm the clinician. And the two together have been incredibly powerful. And I believe in what he does. I do this work regularly, but I think that there are a lot of very scary things going on in the United States right now. So today, for me, is not about, it's very different. It's not about a scientific lecture. It's not, about, talking about the details of this cell and this growth factor and this exosome. It's really a story. It's really a conversation about what I'm seeing. And in fact, this is kind of what I feel like now every day when I go to work. I feel like I'm going into battle, because every day I'm faced with these questions and dilemmas from very desperate people who want answers. So as I said, I hadn't thought about broaching this publicly, and I tend to stay away from the political aspect of stem cells, but I actually can't stay silent anymore. So this is not going to be a particularly well-received talk in certain groups, because I'm just going to lay it all out. I feel that patients are being taken advantage of financially and medically, and we need to have a certain sense of responsibility with what we're doing. So how do we distinguish? You look on the internet and the newspaper every day, and you see tons of things. You're bombarded with all of this data and all of these miracle cures to things. But how do we actually distinguish these? We talk about the fountain of youth, anti-aging. Largely, though, this information, where is it coming from? It's coming from the companies that make the products, you're the exception, and the clinics and the doctors that are performing these procedures. So I'm not saying the doctors have no responsibility either. There's a lot of responsibility to go around for what the place we're in right now, which, as I said, I think is a very scary place that we need to take really seriously, because a lot of harm can happen. So I'm sent articles every day about these things, and I'll touch on that in just a minute. So again, we're promised these cures for everything from MS, Parkinson's, Alzheimer's, ALS, more typical age-related diseases that we see here, cardiac, diabetes, pulmonary diseases, arthritic conditions. Sounds great. Sounds like a miracle right here in the United States. Not so. The flip side, though, are these frightening stories we hear and see, or these warnings of danger. And often these warnings, I'll see patients that come back to me and they'll say, oh, I spoke to my neurologist about what you're suggesting, or I spoke to my rheumatologist about what you're suggesting, and they said, it's going to kill you. It's dangerous. We're not there yet. So I think that this really comes from what I call ill-informed or uninformed physicians that are just not up to date with the current research or data or science. So here I am feeling a responsibility to put myself out there and actually start talking about it. So where does this confusion originate? I already alluded to this. The confusion, I think, is multifactorial in origin, and we all have some responsibility, from the greedy doctors, hopefully I'm not one of them, from the greedy doctors to the fraudulent representation by some biologics companies to inadequate or maybe inappropriate oversight by the FDA, and even to the patients who are victims in a way but desperate, and so they only hear what they want to hear, or they choose, what's being told to them. So we need to look at all of these. So I call this the piggy bank phase of medicine in the United States, because we see dollar signs. There is no magic. It's been alluded to by several of the speakers here. There is no miracle. Some stories are miraculous, and they are extraordinary, and I've seen them, and I love to talk about them, but that's not the case all the time. And so I like to really manage expectations for my patients. So how do I take this apart and not, as I like to say, throw out the baby with the bathwater? Because, again, there's a lot of valid work being done here. When I look at what we can do in the United States, I take it apart in my mind in two pieces. And this has already been alluded to, especially by Dr. Herrera and Dr. Reardon earlier. So I look at the two tracks that we can follow before I make a decision about how I'm going to treat this person for regenerative purposes. The first area that we get into has already been touched on, which is autologous treatment. Treatment that is derived from a product from our own body. A lot of people are much more comfortable with this. I have patients that come to me and they say, I don't want that donated product. How do I know where it's coming from? I want to use my own product. I want to use my own bone marrow, my own fat, my own blood, which are the sources of autologous regenerative treatments that are legal in the United States to some degree, and I'll talk about that right now. So there's blood, which is PRP. We draw blood, spin it down in a centrifuge, it separates the products, and then we re-inject the platelet-rich plasma component the same day back into the area of disease or dysfunction. Then there's fat, or what we call adipose-derived. I think most of you kind of know this. We put it through a fancy centrifugation and filtration system. I'm not a lover of this, and I'll talk about that in a few minutes, but those are called adipose-derived MSCs, mesenchymal stem cells. And we can also source it through bone marrow, which Dr. Herrera talked about, which we call bone marrow-derived MSCs, or something called BMAC. I want to be very clear, taking these apart, and actually I was so glad that Dr. Reardon said this before, PRP is not a stem cell treatment, and it makes me insane when I see things on the internet constantly from these programs that talk about, get a stem cell treatment, use your own blood. No, it's not true. We need to be critical when we look at these things. It is, however, a reasonable regenerative treatment. It relies on circulating factors or proteins that promote the regenerative process through a variety of different mechanisms, and that lists, some of the little shortcut definitions of that's not important to get into right now, of what's in the blood. That's just a picture that I like of red blood cells, sorry. So I think it's really pretty, actually, if you really look at it. I mean, that's a beautiful, real image of red blood cells, which we're not injecting, by the way. Red blood cells should not be a part of PRP. They're very pro-inflammatory, make the injection very painful. But PRP can be a very good choice in certain circumstances. If I have a young, healthy person, a 16-year-old that had a very minor sports injury, it's reasonable to draw some blood, spin it down, re-inject it into that person. I get that. It, however, is very limited in more complex injuries or systemic diseases. I'm not going to take that blood out, spin it, and then put it in intravenously, so I can't have a systemic effect. There are some doctors now, I should say, doing a technique that they call VSEL infusions, which stands for very small embryonic-like cells that are circulating in the blood. I've read the data on that and the research. I'm not yet convinced of the clinical efficacy of it, so I didn't really include it in this talk. The blood, however, does have the advantage, as I talked about before, of being from your own body. And again, some patients are more comfortable with that, and it eliminates the possibility of an immunologic adverse event. So I should step back for a second and say all autologous procedures done in the U.S., regardless of what product you're using, has certain FDA restrictions that we have to meet. And the first and foremost one is that we must deliver it same day. So we have to extract that product, process it, and deliver it the same day. This may be fine for PRP. I don't believe that it's fine for fat in particular. It's okay for certain instances of bone marrow too, but I'll get into the fat issue, which is a real pet peeve of mine in a minute. So bone marrow has a very reasonable concentration of mostly hematopoietic stem cells, you've heard, MSCs as well, but one of the limitations with any of these cell draws, and it's interesting that Dr. Herrera had this on the slide, but he didn't really have time to get into the detail of it. He said either a product, postnatally derived product from tissue, umbilical cord, amniotic, whatever, versus the bone marrow, the bone marrow draw and those cells. And he said there, well, it depends on the overall health and age of the patient. And what he was really alluding to is a very important thing that I take into effect when I'm deciding what I'm going to utilize for my patients. We know that as we get older, it's well established that Dr. Reardon pointed this out also, that there's an inverse relationship between our age and the number, the absolute number of cells circulating MSCs in our body, and we believe the potency. And this is a very famous chart that I just redid by Dr. Kaplan that shows the concentration at birth versus 80 and 80 years of age. And it's exponential, the decline in the concentration or number of cells. So if I have an 80-year-old patient and they have degenerative osteoarthritis in the knee, and I say, wait a second, I can extract bone marrow from that patient, spin it down, re-inject it into the, fine. I don't know, I don't have the ability to look at the cell population. I don't have the ability to really do an adequate assessment of the cell count. Even if I do something called flow cytometry, it's not going to be, really specific. I don't know the character of those cells, but I can do it, and it's from their own body. They won't reject it. Maybe it'll work. Or I can use a postnatally derived product that is processed, if it's processed properly, where we have adequate cell counts, we know what the growth factors are, and it's reproducible over and over again, and it's not dependent on that patient's age. So I go through that thinking process every time I see a patient. Bone marrow, getting back to that, is actually an excellent choice in certain situations. There is a small but growing number of orthopedic surgeons around the country, and I pray for more to do this, that recognize that intraoperatively this can be incredibly valuable. And so they might be doing an arthroscopic procedure of the knee, shoulder, hip, but in the beginning of the procedure, they'll extract some bone marrow from the person, have it processed while they're doing the surgery, and then infiltrate those packed cells into the surgical site just before they finish. The preliminary data on that is really extraordinary for decreasing the healing times and decreasing pain after the postoperative experience. So why wouldn't we do that? It's the person's own product. So there are roles for this type of product, but we are again limited by the same day processing as per the FDA. And the other character limitation that we have with the FDA applies not just to autologous, but also to allogeneic products, which I'll get into in a second also, and that is that we cannot do what they call more than minimal manipulation of the cells. And so I can extract that product, and whatever the cell population is, it is. I can't change the character, the quality, the cell walls. I can't expand it. I can't grow it. It's just what you get is it. That's it, according to the FDA. So there are certain limitations, as I've already gone over. So what about my pet peeve, the adipose, the fat-derived stem cells? This one probably disturbs me the most because this is the one that's taken off the most around the country. This is the one that you see advertised the most on the internet. You can have IV application of your own stem cells after we do a liposuction. Who's not going to want a liposuction, right, in this country? And we're going to process that, put it into you intravenously. It'll be $20,000, thank you very much, and we're going to cure your kid's autism, and we're going to cure this, and we're going to cure that. But number one, what's the age of the person and what's the concentration of the cells, even though fat happens to be a very plentiful source of stem cells? But what's the potency and what's the number? Again, it's unreliable, it's not exact, but more importantly, the safety component is the one that bothers me the most. And Dr. Reardon and I have talked about this. We talked about this probably 6 years ago when people first started doing it in the country. And I swore I was going to pull all my hair out because I keep worrying about that same-day processing element. Is it safe for us to then introduce this product intravenously into a patient? So all of these programs tout, oh yeah, IV application, right here in the US. Why travel to another country and get it done? Well, there's a really good reason why you should travel to another country and get certain things done. I'm not necessarily saying you should have fat done in another country, but there is, again, okay, I'm going to backtrack again. You see that disgusting thing up there? That's what it looks like when I extract fat out of someone. It's thick, it's gross, it clumps up, and it's disgusting, okay? And we know it. We don't like it, okay? But do I really think that I can take that and in a matter of 30 or 40 minutes do a little bit of a type of enzymatic digestion, put it through a fancy centrifugation and filtration process, and make that safe to put in someone IV? Now, I'm not saying that all fat procedures are dangerous. I'm fine with plastic surgeons taking fat out, putting it in the face to plump it up. Maybe someone wants it in their breasts. Maybe they want it in their behind. I don't know why they would want that, but maybe they do. So I'm not saying it's altogether bad, but I would not put that product in my vein, okay? I do not believe, and I can't say this enough times, that processing adequately, if you will, cleanses the cells. And I believe that makes them potentially vulnerable to aggregate and form potentially fat emboli that could have devastating effects. That's intravenous application or specific site injections. There was a story that came out in the news, I think last summer, about 4 people that went blind after using autologous fat-derived stem cell processed the same day and then injected into the retinas in patients with macular degeneration. Now, why those doctors would do both eyes on the same visit the first time anyway is beyond me, and that makes me question their judgment to begin with. But these 4 patients went irreversibly blind. Those are the kinds of complications that I'm not willing to get in my patients. There was an interesting review done by some Danish researchers about 2 years ago. They started looking at over 100 studies. They ended up with 70, which is also interesting because they had to eliminate those remaining studies because they were of such poor quality. But they ended up reviewing 70 studies over 1,400 patients, and the study was limited to adipose-derived or fat-derived MSC treatments, and it was a variety of applications. It was intravenous, intra-articular, intramuscular, and they were looking at 3 specific outcomes: thromboembolic, cancer recurrence, and adverse immunologic responses. Their results, I think, were absolutely predictable. In my mind, is what Neil and I predicted 6 years ago. There's no mystery here. The mystery is why doctors are jumping on this and advertising these procedures. That's the mystery to me. So you see, this is not going to be a popular talk. So the results were predictable. Multiple cases of embolic events were documented: pulmonary embolism, myocardial infarction or heart attack, and stroke or cerebral infarction. That's significant to me, and those are risks that, again, that I'm not willing to take. There was only 1 case out of over 1,400 of recurrence of a patient who had breast cancer 11 months after treatment, and that is not clinically significant. We can't even say that it has anything to do with the treatments that these patients were getting. So I believe, as Dr. Reardon does, and he has the science behind it, that these are not cancer-producing treatments. So that part I expected, and of course I also expected with an autologous product that there would be no adverse immunologic events, and there weren't. The authors, though, put this little addendum, which I thought was fascinating and very reflective of where we are in this country right now, and that is, they said that not all the studies had adequate, and in some cases, no control subjects. So that's really more of an outcome study. That's not really a controlled clinical trial, right? So that's just looking at outcomes. So there were no, as I said, in some cases, no control subjects. Some had no assessment even for adverse reactions at all. They didn't even mention that there were none. And there was inadequate follow-up and timeframes in many of them, and small studies. So ultimately, what does this come down to? It comes down to the responsibility, I think, of the treating physician to do their due diligence and not just jump on the newest and greatest treatments available. We have to use a certain modicum of common sense along with a very deep understanding of the physiologic mechanisms. And Dr. Herrera is a great example of this. He is practicing as it should be practiced. He is looking at the science behind it. He's making informed decisions. And he touched on something else that I'm going to talk about in a minute about these clinics that have opened up. The bottom line when it comes to autologous therapies is that we really need to do more work to assess the safety, particularly fat and particularly IV more than anything. Maybe if we were allowed to process the cells in a safer way over a longer period of time, maybe I would go to the side of saying, okay, maybe it's safe and we should do some studies on it, but we're not even there yet. So again, one of the saddest parts of this portion of the story for me is that the technology does exist to do these things. The technology exists to process these cells safely. The technology exists to filter them safely and to even safely grow or expand these cell populations, but we're not allowed to do it. So now I want to move very quickly to the allogeneic. Allogeneic being products derived from another human source. I have literally now 2 minutes left. So postnatal products, what are they? Where are we allowed to process them? We actually are allowed to process postnatal products in the US, umbilical cords, umbilical cord blood, amniotic tissue or fluid, and placental tissue. So as Dr. Reardon said, the FDA allows us to process this tissue, but not the stem cells per se. And so that's another thing that gets me when you see the advertising of these companies and they say our product has, 5 million live stem cells and all these growth factors per cc of product. Well, most of the labs, the biologics labs that process these materials, actually the stem cells die in the process, and there are very few live stem cells in here. So we're not allowed to change the character. We're not allowed to do anything to those cells. Dr. Reardon has found a way within the restrictions of the FDA and what's legal in the US to save the integrity of some of these cells and utilize them. I use his product, obviously, so I'm not denigrating that. There are tight restrictions, however, on how we use them, as I've said, how they're processed, and there are various ways, creative ways now that doctors and clinics are structuring these under what are called government-sanctioned IND or IRB protocols. And that's the next area that makes me a little crazy. So a patient will come in and say, oh, the doctor said that this is an FDA-approved, sanctioned under an IRB protocol study, and it's going to only cost me $30,000 to get it, okay? And in what world do serious clinical trials cost a patient $30,000? Serious science doesn't cost the patient anything. There are double-blind controlled studies where someone gets the product, someone doesn't. We're looking for safety. We're looking for efficacy. Why should a patient pay us when we don't even know what the outcome is going to be? We don't know if it's safe. So that actually gets me also crazy, as you can tell. So we have to beware of what are called now these patient-funded studies. I'm extremely critical of them, whether they're allogeneic or autologous. There are a lot of them going on now in the US with fat-derived. And this is another element of it. There are doctors around the country that have gotten IRB approval to do a certain procedure of processing, same-day processing, let's say, of fat, with a certain application of that fat. Those doctors and clinics now are holding workshops for doctors from around the country. So these doctors from around the country go to these workshops, pay that original doctor large sums of money to learn their procedure, but then if they want to use the procedure, that is, they think FDA approved and sanctioned, and they think safe, they then have to pay that original doctor more money to use that protocol. But then it becomes a multi-center trial. So the original doctor in Texas would then find a clinic that wants to use it in New York, and one in Arizona, and one in Oregon. But are these really clinical trials? No. They're just selling another technique as it's safe, somebody's making a lot of money, hence the patients that went blind. Hence the other stories, which I'll get into in a second also. So I'm very critical of these patient-funded studies. So what about the labs that process the product? Almost anyone with enough money can, in these days, in the US, can open a biologics processing lab. All they have to do is really register it with the FDA, and they can begin selling their product. Well, what about the advertising, which I've run into, of facilities that say, oh, we have our own lab and we process the best material. They don't compare it to anybody else. They post lies about the concentrations of cells. And then if you take the step to actually go and visit that facility, it doesn't exist. They're middlemen. They've contracted with labs. They have no idea what the processing is doing, what's happening behind the scenes, and they charge huge sums for that product then to go to the doctor, to the treating physician. And so there's all these levels where if your doctor, and Dr. Herrera also said this about trusting your physician, if your doctor does not do proper research and really know what to ask for and what to look for, you may too be getting a product that you have no idea where it's really come from or how it's been processed. So that is another element of the Wild West in the US. There are currently well over 800 of these facilities in the United States professing these magical cures, anti-aging, hair replenishment, regeneration, ED, all of the things that the buzzwords that people want to hear. You know, who wouldn't want to function better and look and feel younger? So although the FDA has limited oversight over certain aspects of this, they do have oversight over the actual lab processing under what was called GMP processing and standards. Why? I don't understand that why only a fraction of those over 800 labs have actually, in fact, been visited or vetted by the FDA. So that's where I was. So when I walk into a lab, you saw a picture actually before Dr. Reardon showed of his lab, and that person was fully covered, right? That is a proper, clean processing room in a lab. But my fear is this. That's my fear about what's going on behind the scenes. And to that point, a lot of labs actually do cut corners. They don't utilize proper sterility control and infectious disease testing. They don't have a proper chain of custody of the product, which I'll explain at the very end in just a second. These are actually the companies that have the slickest marketing. And those reps go into doctors' offices and they talk about all this magic stuff and how the doctor can charge tens of thousands of dollars for these procedures, but the doctors actually have no idea what that person's telling them, most of them. They have no idea the science behind it, and they are believing what these very flashy reps are telling them. And then that passes on to the patient, who believes what their doctor is telling them. This has to stop. Okay, so what about these so-called clinics, now numbering thousands in this country, that charge all this money? Many of them, as was alluded to before, aren't even physician-owned or run. Okay, that is disgraceful. There are a growing number of chiropractic clinics, for example, around the country that do these regenerative. There goes my whole thing with chiropractors, sorry. I'm not anti-chiropractic, by the way. But there are a growing number of these clinics that are doing these treatments. Chiropractors are not licensed to inject or do IVs. So what are they doing? They're hiring nurse practitioners or PAs to do the actual procedure. But where is the physician oversight? Where is the physician evaluation? Where is the physician looking at the products and the processing of these products? Great example. A few months ago, my cousin called me. She lives in Arizona, and she's got really bad osteoarthritis of the knees. She was told she needed knee replacements. She calls me and she said, oh, I went to this lecture from this doctor in Scottsdale, and he said, it's incredible. He can inject these umbilical cord-derived stem cells into my knees, and it's going to be cured. What do you think? Because I know you do this stuff. And so we're talking, and I'm asking her more questions, and as I'm asking her more questions, it turns out that the doctor that she heard was a chiropractor. And when I explained to her that the chiropractor couldn't do the injections, she was stunned. What stunned me was that the chiropractor in Scottsdale, Arizona, charged 50% more than I do in New York City with all my training and degrees and the highest, rent district in the country. He's getting more money for these procedures. Again, where is the oversight of this? So coming to the end now, how do I assess these products for safety when I'm looking at this? There's certain, and I'm talking about allogeneic now, biologic products. I go through a whole list of things in my mind before I will ever order from any lab, and I would promise you that most of the doctors don't do this. And we need more education about how to do it. So the first thing I like to know is I want to make sure that those donors are local, that the lab isn't really importing cells or product from Mexico or Russia or wherever they might be importing them from. So I want to know that that lab has an agreement with local obstetricians, that those obstetricians ask their pregnant patients, if you go to a cesarean section, would you be willing to donate your afterbirth for medical purposes? If the woman says yes, there's a questionnaire information sort of screening thing that they do, which is only as good as the paper it's written on, but at least it's a first level of screening for the product and the donor. I also want to know that that raw material is from a cesarean section, not a vaginal delivery. Vaginal delivery is a dirty portal. A cesarean section is a sterile surgical field. So I want to make sure that that product is local, is screened, and is from a live cesarean section. I want to know that when that woman goes into labor, that the obstetrician contacts the lab that they have an agreement with, and either the lab sends an actual representative in the operating room to collect the material in a safe and proper way, or that they have proper packaging that was given to the obstetrician for them to then send the product safely under sterile, temperature-controlled conditions to the lab for processing. I want to know that that lab is GMP standard or above, and preferably has been visited, not that they love this, but visited and vetted by the FDA. I know that Dr. Reardon's labs have been. I know that they are world-class and some of the best processing labs that exist ever. So I want to know these things. I also want to know that that lab, as part of the GMP standard, has adequate temperature, storage area, and sterility control. I also want to know that that lab will occasionally send samples of a batch out to an external lab to eliminate for internal bias in that lab. There was a devastating case in the news, which it's about time, okay, where it was written up as 12 patients getting sick from umbilical cord MSC used intravenously with E. coli infections. It was from one particular lab in California, and when the reports first started coming in, the lab denied responsibility. They said it's dirty technique on the part of the physicians. And then as more reports came in, and I'm sure there are way more than 12 that were actually reported, but as the reports came in, the lab could no longer really deny that this may have come from their lab. The FDA went into that lab and they tested 10 batches, a sample from 10 batches of their product, and 7 of those batches grew out E. coli. Where is the oversight? And out of those 10 batches, none of them had any live stem cells in them, and they had very diminished growth factor populations in it. So patients were basically paying $20,000, $30,000 for glorified saline, I think. So this is the kind of thing that I want to know. And then what do? I physically go wherever that lab is, and I look at it. I want to look and confirm that what somebody's telling me is real. They can tell me there's 5 million stem cells in there. I want to see it. I want to see that product. You know, Dr. Reardon does these beautiful comparisons that are necessary with data, with science, with pictures. That's what we should believe, not just what anybody tells you off of the internet or in your doctor's office for that matter. So basically, if something seems too good to be true, it is. And that's my applause. Sorry.